once again. Good afternoon. We are going to discuss another syndrome. Today we are discussing prostatitis, and from the name, you already have an idea of what we are discussing. So by the end of my talk with you today, you should be able to give a definition of what prostatitis is, and you should be able to discuss the spectrum of clinical presentations that you can have. Now, my emphasis will be on laboratory diagnosis in terms of specimen collection and how you make sense out of the results. So I'll only give you a guideline to management. So the focus of the discussion is bacterial prostatitis, okay? Because if we say prostatitis, that's just saying you have inflammation of the prostate gland. It could be due to microbial invasion, it could be due to other causes. So my emphasis is going to be on bacterial prostatitis. And in this condition, you have inflammation of the prostate gland and the surrounding tissue as a result of microbial invasion, usually bacterial agents. Now, in terms of classification or clinical presentation, you have four classifications or four presentations. You can have acute bacterial prostatitis. The word acute suggests that it's something that has a recent or sudden onset. Then you have chronic bacterial prostatitis, which suggests that this has been going on for some time. Then you have chronic prostatitis or chronic pelvic pain syndrome. It's distinct from chronic bacterial prostatitis. And then you have asymptomatic prostatitis. So by definition, the important component of your description or your definition of bacterial prostatitis is that you have evidence of bacterial invasion. So there's presence of pathogenic bacteria from secretions from the prostate gland, and there's evidence of inflammatory cells. So the bacterial agents are not just present, there's evidence that there's post-immune response to their presence. In young men, this condition is rare. However, about 50% of all males will develop some form of prostatitis at some period in their life. So let's look at each presentation a little bit in detail. When we have acute prostatitis, this is usually characterized by a sudden onset of fever, tenderness, and urinary, as well as constitutional symptoms. With chronic prostatitis, most of these acute symptoms are no longer present. So they present with very few symptoms related to the prostate gland. But you have symptoms of urinary difficulty. So now patients may tell you that I strain to pass urine. There may be evidence of low back pain, perineal pressure, or a combination of all these symptoms. Chronic prostatitis represents a recurring infection, and we're going to find out why. Usually it's the same organism, because when you treat, at times the agent you're using may not penetrate the prostate gland effectively, so you still have organisms that will survive, and then after some time they start to replicate. So it's usually the same organism. And this is because, like I said, you have incomplete eradication of the bacterial agent. So apart from the conventional pyogenic bacteria, sexually transmitted agents such as gonorrhea, Neisseria gonorrhoeae, chlamydia trachomatis, and the atypical agent Ureaplasma urinalyticum may be etiological agents of this condition, particularly in young sexually active men. Now remember, we said young men and they rarely come down with prostatitis. So if you have a male patient, a relatively young male patient, and there is evidence of prostatitis, you should be thinking of sexually transmitted agents. Is that clear? Also, patients with HIV/AIDS, young men with HIV/AIDS, they may also present with agents that are sexually transmitted as cause of their prostatitis. These other agents are rarely involved in prostatitis. So fungal agents, mycobacterium, tuberculosis, and viruses, you hardly have them. But if the patient is severely immunocompromised, maybe they may show up, but it's not something you will expect. So what are the risk factors for bacterial prostatitis? For both the acute or the chronic, these conditions predispose to bacterial prostatitis, benign prostatic hypertrophy, when there's genitourinary infections with backtracking into the prostate gland. Men who engage in high-risk sexual behavior, for example, men who have sex with men, history of sexually transmitted infections, urodynamic abnormalities, patients who are immune compromised. If for any reason the patient came to the hospital and you performed some form of prostatic manipulation, so it could be iatrogenic. Performing cystoscopy at times when you don't observe complete asepsis may introduce organisms into the prostate. Undergoing a procedure such as transrectal biopsy of the prostate gland could result in prostatitis. In patients who have urethral stricture, maybe following poorly treated STI, or because they've had previous history of instrumentation such as catheter insertion, so they now ended up with a stricture. You know, with stricture, you're going to have some degree of obstruction to urine outflow. So the residual urine can serve as good culture medium, and from there you can have bacterial agents getting to the prostate gland. So what is the pathogenesis like? Remember, we said in the definition, when we're talking about bacterial prostatitis, you need two things: evidence of microbial invasion and evidence of the host response to the presence of these agents. So you have inflammatory cells. So the natural question is, how did these bacterial agents gain access to this site? One, it could be by ascending through the urethra after infected urine is refluxed into the prostatic ducts. Infection could also result from hematogenous spreading. Of course, this is not as common as the ascending route. And in this case, we've discussed, the risk factors. So iatrogenic procedures could result in direct inoculation of bacterial agents into the tissue. In most cases, bacterial prostatitis occurs secondary to acute or recurrent UTIs. Less commonly, complications from poorly managed sexually transmitted infections such as epididymitis, urethritis, could also lead to bacterial prostatitis. In men who have chronic indwelling catheters, in men who have poor control of their diabetes mellitus, and in men who are immune suppressed or immune compromised, they are at a higher risk of developing bacterial prostatitis. And the reasons include the presence of foreign devices, such as the indwelling catheter. Remember, we discussed this yesterday, that organisms will form biofilms, and these biofilms will prevent them from being cleared by the immune system or being treated by the antimicrobial agent that is being administered. So from here, from this foreign body, the bacterial agents can eventually find their way into the prostate gland. Hyperglycemia in people who have poorly controlled diabetes mellitus is another condition that can favor development of prostatitis. And impaired immune responses cannot control bacterial multiplication. So from the beginning of my talk with you relating to urinary tract infections, E. coli has been a recurring agent that we said is top on the list. The story is still the same with the prostate gland. So the predominant organism associated with this condition is Escherichia coli. Although we have gram-positive organisms such as Enterococcus, which is usually from the patient's gut, as agents that could lead to prostatitis, E. coli is still top on the list. Is that clear? So this table gives you a summary of the various presentations of prostatitis. Remember, we said we can have acute chronic bacterial prostatitis, CPPS, and we can have asymptomatic prostatitis. So why I like this table is that the information relating to the symptoms and how you can elicit signs are together on one page. So you can go through this table. It's self-explanatory. So you have a patient with these symptoms, okay, and you're thinking it's likely to be prostatitis. What do you do? The diagnosis of the acute form of the condition involves the clinical presentation. How did this patient present? In the acute phase, the patient will have constitutional symptoms such as fever. Patients will have urgency, dysuria, hesitancy, all the features of urinary tract infection. Then you're going to send the urine sample to the lab. And if the lab is able to demonstrate the presence of significant bacteriuria, that confirms your suspicion. As with other UTIs, the infecting organism can be isolated from a midstream specimen, and you know how that can be collected. With chronic prostatitis, the picture is a little bit blurry. It's not so easy to make a diagnosis. So the patient may present with features of recurrent UTI, but most of the time, it's the same organism that is isolated. We already explained this in the definition. The patient's clinical presentation can also vary, so there's no one size fits all. You need a high index of suspicion, so you have a real patient, recurrent UTI. You treat the same agent, so maybe you should start thinking, maybe I'm not dealing with cystitis, maybe I'm dealing with prostatitis. Okay, so that's the way to figure things out. But then, if you have a strong suspicion, how can the laboratory help you to confirm your suspicion? We perform what we call a urinary tract localization study. So the important thing is you're going to try to collect the sample in such a way that a particular sample is indicative of a significant growth of bacteria compared to the others. So how do you do this? Okay, before we go to how you collect your sample, you should know that E. coli strains that are associated with prostatitis usually have higher virulence factors and greater degree of biofilm formation. So this further enhances recurrence. So how do you collect the sample when we want to perform a quantitative localization study? This procedure was described by these two men, Mears and Stamy, and it is regarded as the diagnostic standard. The method compares bacterial growth in sequential urine and prostatic fluid cultures that are obtained during micturition. So how do you collect the sample? So here you have this diagram, and the reason why I like this particular diagram is because it gives you an idea of what we mean by localization, okay? So when you're ready to evaluate the patient, there are 4 tubes or 4 glasses that you're going to hand over to the patient. Now, when the patient starts micturating, the first 10 mils of urine that is passed represents what you have in the urethra. VB stands for voided bladder. So voided bladder 1 represents urine sample from the urethra. That's the assumed site that the urine is coming from, okay? So whatever organism you have in here will be washed away into the VB1 sample. Is that clear? So the patient will continue to pass out urine. Then you go for the midstream. You know what we said about midstream. Now the midstream comes from the bladder. So whatever sample is getting into your VB2, which is voided bladder 2, that sample is believed to be representative of whatever is going on in the urinary bladder. So whatever organism is there is washed out in this VB2 sample. So that's why you have a corresponding purple color in the bladder and in the tube. Here you have the yellow color in the urethra and in the tube. So that's to tell you this is the site. Then, because you have a patient with chronic prostatitis, not acute, you're going to carry out what we call a prostatic massage through a digital rectal examination. If the patient has acute prostatitis, please do not attempt this procedure. Do not massage the prostate of a patient with suspected acute bacterial prostatitis. Why? You're going to disseminate the bacterial agent. So a localized infection becomes systemic. So it's contraindicated. Apart from the fact that it's painful, you can disseminate the infectious agent. So here, you're going to massage the prostate, and it is believed whatever purulent material that is present is expressed into the prostatic urethra. Okay? So you, by massaging, will get out whatever secretion is here into the glass tube. So whatever you have in the EPS means expressed prostatic secretion. Whatever you get into the EPS represents what you have in the prostatic urethra. Are you following? Then the final sample you collect, which is the VB3. After the massage, you're going to ask the patient to go and pass out urine again, and whatever is coming now will be urine that will wash out whatever maybe you were not able to express enough secretions into the third tube. So whatever is here is mixed with the urine from the bladder as VB3. That's why you have these greenish specks in the purple urine. Is that clear? So that represents whatever is present in the prostatic urethra and the urine coming from the bladder. Is that clear? So each tube represents a particular site along the urinary tract. So how do you make a sense out of this? Okay, this is just showing you the steps. Okay, so the 10 mils, we normally collect 10 mils of urine. And like I said, VB1, VB2, VB3, the VB stands for voided bladder. VB1 is from the urethra, VB2 represents bladder urine, then you're going to massage the prostate gland, and then you have VB3, which represents a mixture of whatever is in the urethra, prostatic urethra, and the bladder. So you send everything to the lab and we're going to culture, but we're going to carry out a quantitative culture. You know how we do that already. We discussed that in the first lab. So how do you now make sense out of what you have? You're going to compare the number of bacteria, colony forming units, in the expressed prostatic secretion with the other urine samples you collected initially. So the VB1, the VB2. The VB1 represents urethral sample, and the VB2 represents the midstream urine from the bladder. Now, if the colony forming units, the number of bacteria in the EPS is 10 times more than what you have in either VB1 or VB2, then that is indicative of chronic prostatitis. So your lab has helped you to make your diagnosis. Are you following? Like I said, at times you may not get enough EPS to express into the third tube. In that case, the VB3 is what you fall back on. Again, if the count is more than 10-fold what you have in VB1 or VB2, that's diagnostic. Is that clear? So this table is just giving you a summary of the different presentations that you can have, how you can, define the condition, what we look out for in the lab when we carry out the 4-glass test. Now remember, I told you that in a patient with suspected acute prostatitis, do not massage the prostate gland. Apart from the fact that it's very painful, it's also going to disseminate the pathogenic agent. You should also note that with acute bacterial prostatitis, you may perform the 4-glass test, but you should note that you skip the EPS. Okay? And it is believed that the EPS will be positive, but it's contraindicated. Okay? If the urine or the semen cultures are not diagnostic, so the count is not clear-cut 10 times above VB1, VB2, but it's elevated, but not just to the defined, the set criteria, what can you do? There are additional things that you can do. The first two are in red because this is what the micro lab will do. But the others, you may need to involve other laboratory services. So you can perform the two-glass test. So in this case, you're only going to collect sample VB1, you massage the prostate, and then you collect VB2. You may have to carry out a screening test for sexually transmitted agents. So you collect a urethral swab, you can perform microscopic culture and sensitivity test, or you can perform molecular assays for specific agents. So in terms of management, you have to give antibiotics. I'm sure you will discuss this in the pharmacology lectures, and of course you have to involve a urologist as part of the management team. Any questions? Yes.
Yes, doctor. Can you go back to the picture with the 4 cups or samples?
This one or this one?
This one, yeah. So for EDS, you do a digital rectal massage. For EDS, how do you collect the VD3?
How do we collect VP3? The patient does that. So after massaging the prostate gland, you allow the patient to go and pass urine again.
Okay, so 4 samples.
Yes.
Yeah, in acute bacterial prostatitis, if you're not giving a prostatic massage, wouldn't VB2 and VB3 be the same thing?
Actually, with prostatic, with acute bacterial prostatitis, just collecting the midstream urine is adequate because the patient has overt symptoms. Okay?
Yeah.
Remember, it's the chronic one that is a little bit dicey, you're not sure, so you need to localize. In the chronic prostatitis, you still have bacterial growth in the midstream urine, but you are not sure where is the infection. That's why you have to do this 4-glass test or 2-glass test, depending on the situation. Any other question? So enjoy your weekend.